giving me this opportunity to chair this session this afternoon. We have 4 important and very interesting cases for presentation today. And there's a small change in the order of presentation. Since the pediatric department from the SRM group has to attend a dean's meeting at 2 p.m., there's been a small request from them that they would do the presentation first, but the remaining presentations will go as per schedule. So the first presentation today would be an uncommon progression of atypical febrile seizures. So I now invite Dr. Sri Dharani, second year postgraduate from SR Medical College and Hospital, to do a presentation.
Thank you, ma'am. Good afternoon all to all the respective faculties and my colleagues. Myself, Dr. Sridharni, a second year postgraduate, and I am here to present about a case of an uncommon progression of atypical febrile seizure. And my moderator is Dr. Ramakrishna Sanjeev sir, and done under the guidance of Dr. Robert Wilson, who is a pediatric neurologist in SRM Medical College. So this is a case of a 12-year, 4-month-old child who's a known case of seizure disorder on anti-epileptic with a history of poor compliance, came to a pediatric department with abnormal movements noticed by the mother for the past 4 months. Child is developmentally normal, third born to a non-consanguineous married parent. So coming to the history, child presented to the pediatric OPD at 12 years of age with a 4-month history of recurrent stereotyped episodes. And these episodes typically begin with an unexplained dry cough, followed by urge to pass urine and with the abdominal discomfort, which is later followed by a behavioral automatism, including like pulling of clothes and lip smacking episode. During some of these episodes, child goes to a restroom, locks the door, but does not pass the urine and is later found sleeping on the floor. And during some episodes, child just sleep wherever she's standing. The child had these type of recurrent stereotyped episode with behavioral abnormalities associated with impaired awareness lasting for about 10 to 15 minutes, followed by post-ictal drowsiness lasting for 30 minutes to 1 hour. And these episodes occurred with a frequency of 3 to 4 episodes per week for the past 4 months, with a recent increase in frequency and duration noticed over the past 1 month. And child did not present with any history of tonic-clonic movements. No history of child did not have any history of persistent headache or persistent vomiting, no history of any diplopia or limb weakness, and no history of regression of milestones, and no history of any auditory or visual hallucinations, and no history of trauma was noted. Due to this recurrent stereotypic episodes, which is occurring frequently and lasting for few minutes, child becomes withdrawn during these events, and as the days passes by, parents report to have significant social embarrassment during these seizure episodes, particularly when they are in any public events or schools. Because of this fear of this social stigma, family also started restricting participating in social activities, ultimately affecting the child's psychosocial functioning. So, on eliciting the past history, at 9 months of age, a child had a first episode of febrile seizure, which was characterized by generalized jerky movement of all 4 limbs with uprolling of eyes lasting for about 2 to 3 minutes, which was self-aborted, following which child had a history of left upper and lower limb weakness lasting for about 3 to 4 days. And during that time, imaging was not done and child was started on clobazam prophylaxis. From 9 months to 8 years of age, child did not develop any seizure episodes and remained seizure-free despite having fever episodes. At 8 years of age, around July 2021, during playing, child had initially a history of aura and a history of fever for 1 day, followed by which child developed seizure in the form of stiffening of left upper and lower limb, uprolling of eyes, drooling of saliva, and head deviated to left side. And this episode lasted for more than 30 minutes, which was suggestive of febrile status epilepticus. Initially, child was taken to some nearby hospital, later brought to SRM hospital, and seizure was terminated with IV midazolam and phenytoin. So during that admission time, EEG was done, which showed epileptiform activity in the right temporal region with slowing of waves, and CT was done, which was shown to be normal. And following which, child was discharged on oral phenytoin for 7 days and stopped, and was asked to continue on the carbamazepine, oral carbamazepine, and follow with neurologist. But the child had a poor compliance with anti-epileptic medication with history of missed doses, particularly during morning time, as the child has to take the dose during the school time. So, eliciting the antenatal history, there was no significant history noted in the antenatal period. Birth history was normal, cried immediately after birth, and there was no significant perinatal history and no signs of birth asphyxia. Child was immunized up to date as per national immunization schedule, and diet history, there was no significant calorie and protein deficit noted. Coming to menstrual history, child attained menarche at 12 years of age, where a history of the similar seizure episode was noted at the time of menarche. Otherwise, the cycle was regular, occurring every 28 to 35 days, and beating lasts for about 3 to 5 days. And there were no features suggestive of catamenial epilepsy was noted. Developmental history, child was developmentally normal, milestones are attained appropriate for age, and studied grade 6, and mother has noticed that there was a reduced scholastic performance in compared to the earlier period in the last 4 months. And socioeconomic status, according to modified Kupusami scale, a child belongs to class C, which is lower middle class. So this is the three-generation pedigree chart of the child, where there was a significant family history was noted. History of cousin death in the paternal side was due to a seizure episode, but it was due to drowning preceded by a seizure episode. And there was also history of seizure disorder in paternal aunt, but the documents of this seizure episodes and death thing was not available. So summarizing the history, this the 11 year to 8-month-old girl, a third child of non-consanguineous marriage, was developmentally normal with history of febrile seizure at infancy, followed by febrile status epilepticus with features of localization at 8 years, was started on anti-epileptic medication but with history of poor drug compliance, presented with history of several episodes of stereotypic abnormal behavior for the past 4 months. And next I would like to examine the central nervous system. So general examination, a child was examined while lying comfortably on bed. She was conscious, oriented to time, place, and person, and there was no pallor, icterus, sinus clubbing, and lymphadenopathy. On examining the vitals, pulse rate was 102 per minute, regular in rhythm, normal volume and character. No radiofemoral delay was noted, and all peripheral pulse were well felt. Respiratory rate was 22 per minute, abdominothoracic type of respiration, and BP was 104 per 72 mm mercury, measured in the right upper limb in supine position, and child was maintaining normal room air and normothermic. On anthropometry, height for age was 147 centimeter, belonging to 75th to 90th centile, and weight for age was 50 kg, which was 75th to 90th centile, and BMI was 23.4, which is 58th to 75th centile, and head circumference measured was 51 centimeter, which is 50th to 75th centile. Head to toe examination, head appears to be normal in size with no dysmorphic features was noted, and SMR staging was stage 2, and there was no significant neurocutaneous markers. On examining the higher mental function, child was conscious and oriented to time, place, and person. On eliciting the memory, the immediate memory was found to be intact, but the recent and remote memory when tested was slightly impaired, and speech was normal. Cranial nerve examination was done, and no significant abnormality was noted. On motor system, the tone of the upper and lower limb was normal, and power was also found to be normal. Reflexes elicited were found to be normal, and no significant abnormality was noted. Sensory system was examined, and there were no significant abnormality, and even cerebellar functions were found to be normal. There were no bowel and bladder dysfunction noted. Gait was normal, and spine was appeared to be normal. So other system examination were done, and it was found to be normal only. So the professional diagnosis of this is 12-year-old girl with recurrent focal seizure with impaired awareness was suggestive of focal seizure with impaired awareness as per ILAE classification. So during this time of admission, following investigations were done: the routine bed investigations, EEG, and MRI brain. So this was the EEG which was done at 8 years of age, where the even numbers represent the right side of the brain, and the odd numbers represent the left side of the brain. And there was it was noticed to have slowing of waves, and spike waves were noted over the temporal region. Comparing to that of the frontal and temporal, there was slowing of waves which was noted at in the EEG, which was done at 8 years of age. And EEG, which was repeated at 12 years of age in the current episode, there was no significant epileptiform activity noted, which was probably could be due to the anti-epileptic medication which was used by the child. The MRI brain done, which during this current hospital stay. This is a T2 weighted coronal section of MRI image showing hippocampal atrophy over the right side compared to that of the left side. And there was a T2 hyperintensity images noticed in the right side of the hippocampal area with the loss of the volume. So this is a triad which is seen in the MRI finding of mesial temporal sclerosis, which is increased T2 hyperintensity in hippocampal region, hippocampal atrophy, and loss of architecture. So with a diagnosis made of mesial temporal sclerosis. So this is the summarizing the clinical current history. At 12 years of age, child presented as a recurrent stereotype episodes, and now child was started on continued with the carbamazepine and the clobazam, and child had no seizure episode for the past 2 months, which showed good response. So discussing about the mesial temporal sclerosis, which is also commonly referred to as hippocampal sclerosis, which is most common in the adults and seen 1 to 5% in children and adolescents. It mainly affects the hippocampus area that is involved in the memory, formation and retrieval, and the amygdala, which is involved in the emotional processing. As per the European Journal of Epilepsy, 3 to 3.5 cases per 1 lakh cases noted every year. So coming to the pathophysiology, the seizure which initiate from the cerebral cortex spreads to the hippocampus, which disrupts the synaptic connections, and structural lesion, which is caused by the prolonged febrile status epilepticus, will alters the synaptic connectivity and with the reorganization of circuit in the inner molecular layer of dentate gyrus, which forms a recurrent excitatory circuit. Because of this recurrent recurrent excitatory circuit, the neurons are present in the hippocampal area, that is CA1 and CA3 are more vulnerable, ultimately leading to the sclerosis, which is seen on the MRI image. So there is this study going on, which has been happened in 2025. This is the FEPSTAT study. It is done in the US based. So FEPSTAT and two affiliated studies recruited children with febrile status epilepticus and simple febrile seizure to evaluate hippocampal sclerosis. They have found that the hippocampal T2 hyperintensity after febrile status epilepticus represents acute injury, which often evolves to hippocampal sclerosis after 1 year. And finding from this study indicate that prolonged febrile seizure are likely to be focal, and hippocampal sclerosis is more likely to be associated with febrile status epilepticus. So classifying the mesial temporal sclerosis, basically there are four types of mesial temporal sclerosis. But type 1 is the classic one, which is seen in 60 to 80% of cases. And age of initial precipitating lesion is less than 3 years. And there is a significant loss of pyramidal neurons, that is CA3 and CA4 neurons. And type 2 and type 3 is similar, but loss of neurons is less compared to that of the type 1. And in type 4, that hippocampal sclerosis will not be evident on MRI imaging. And how does it present? Mesial temporal sclerosis is associated with a focal seizure and can also present as tonic-clonic seizure with and without impaired awareness. So seizures often begin with a feeling of rising sensation in the stomach and throat with a history of deja vu or fear or anxiety or pause in behavior, which is known as behavioral arrest. So, and the motor features can also present with in the form of abnormal twisting motions of the hand or with automatic movements like hand picking or fumbling or mouth chewing and lip smacking. Some seizure can evolve to a generalized tonic-clonic seizure, and it also involves the language and memory area. So it is associated with inability to recall, with a transient inability to speak or inability to understand language during and shortly after the seizure. So how it is treated? So the first line is always the anti-epileptic medication, and the drugs used are for the same as the drug that is used in the focal seizure episodes. So for initially we can give it as carbamazepine or oxcarbamazepine or clobazam or phenobarbital or newer drugs like topiramate, lamotrigine, and zonisamide can be used. If seizure is not resolved even after 2 or 3 anti-epileptic, it is termed as intractable mesial temporal epilepsy, for which surgical resection is recommended. If it is unilateral, then surgical resection can be considered. If it is bilateral, then it can go for a responsive neurostimulation, which is a device which can be placed in the brain. And this device detects the seizure activity, and it also detects the site of origin so that it can be used as a palliative resection at a later time. So we have a two surgical option. One is a minimally invasive technique, which is a laser interstitial thermal therapy. And the second one is the invasive option, which is the opening of skull and to resect an area of the temporal lobe known as anterior temporal lobectomy. And it's known to have an improvement in 75 to 90% of the patient. So takeaway point is mesial temporal sclerosis, one of the cause of focal epilepsy with impaired awareness, characterized by typical seizure semiology and hippocampal changes and on MRI. And early recognition and appropriate anti-seizure therapy are essential as it can significantly improve seizure control and quality of life. And to conclude, not all behavioral abnormalities are psychological. And these are my references. Thank you, ma'am.
Dr. Sri Dharani for this nice presentation.
Thank you.
EEG interpretation or the EEG images was very nice. Also the MRI, the classical triad to diagnose mesangial temporal epilepsy also was very, very nicely brought out. So thank you for this nice presentation. And now I'd like to invite Sanjeev sir for his expert comments.
Yeah, madam, Dr. Robert is here. He's the pediatric
Yeah, sure,
neurologist
sir.
who was treating. So we can ask
Sure,
him
sir.
to give his comments.
Sure, sir. Thank you, sir.
He's on the line.
Yes. Good afternoon to everybody. Madam, thank you for the opportunity given. I congratulate the presenter and Sanjeev sir for extensively evaluating this patient. They have done everything in the proper manner. I would like to add few points. The clinical seizure semiology is very important in this case. There are certain points in the semiology, the way in which the seizure progresses, which will give clue to the lateralization and localization of the epileptic origin. So the child has aversive head and eye movements to the left. So that indicates right-sided epileptic origin on the right side of the brain. The localizing value is at by the automatism, hand automatisms and the abdominal aura. Abdominal aura is localizing to the temporal lobes, and urge to void. This child had a particular specific feature as urge to void urine every time. So this indicates the insula is involved. When the seizure activity spreads to the insula, they will have such features like urge to pass urine, pilomotor erection, and palpitation. All these autonomic features will be seen when the seizure spreads to the insular region. So these will give the automatisms, especially the video is not available for interpretation. But anyway, unilateral hand automatisms indicate the seizure origin is on the same side of the the hand, which portrays automatisms. So there are some these are some clues. Also the the child coughs during the seizure episode. The ictal cough also localized to the right hemisphere. So these are the clues which will help us to do lateralization and localization of the epileptic origin. So, and regarding the febrile seizure and further development of mesial temporal sclerosis, there are certain risk factors. When they are present, they will lead to temporal sclerosis in the future. So this at 9 months, the first seizure at 9 months is a risk factor. So this is very early for a typical febrile seizure. So early onset of febrile seizure is a risk factor for future temporal sclerosis. And during the first episode, the child had postictal palsy, left-sided postictal palsy. These are the high risk factors for future development of temporal lobe epilepsies. And nowadays, there are genetic factors also which will contribute to the both febrile seizures and subsequent development of temporal sclerosis, as there is family history of some seizures in the family. So the management aspect, they have told everything in right way, madam. That's all, madam. That's from my
Thank you,
point.
sir. And at what point would you consider surgery, sir? Because almost 2/3 are, I said, literature says even 90% of them are drug resistant and would require some form of resection of the hippocampus, being a scar in the MRI and all that. So,
yes, madam, almost 50% of them will become refractory in the later course of the seizures, madam. Some patients will respond to anti-epileptic medications. When two appropriate drugs are given at appropriate dosage, if even in spite of that, if the seizure continues, that is called medically refractory epilepsy, madam. So the child is under control, but
Fortunate.
later during the course, she may enter into a refractory state, madam.
So one more small comment. This febrile status
Yes,
epilepticus In pediatrics, we normally say the classical age is between 6 months to 5 years, sir. Febrile seizures becoming
Yes, madam.
status epilepticus. But here
Yes,
at
madam.
8
Yes, madam.
years of age, it was mentioned febrile status epilepticus, sir. So a small comment. So we still accept
yes,
this.
madam. Yes, madam. It is common. It is not very
6
rare,
months to
madam.
5.
But yes, madam. That the focality is the main risk factor here, madam. The child had left-sided weakness following the seizures for 1 or 2 days,
First.
madam.
Yes, sir.
Yes, madam. Yes, madam.
But thank
Atypical febrile fits can present after 6 years also.
Yes, madam. Yes, madam.
Beyond the age can present as atypical seizures.
Yes, madam. Yes, madam.
Thank you, ma'am. Yes, ma'am. So thank you, sir, and thank you. I thank both the presenter and the moderator for their excellent presentation, as well as how nicely they have discussed the case for us. So thank you so much for your contribution, sir. Now, thank you, sir.
Thank you.
Yeah. So now we have second presentation. The topic is an unresolved try, lessons from the emergency room. We have our own postgraduates, final year postgraduate, Dr. Prema Lakshmi, to present this case. And we wish her good luck because there should not be any technical snag this time, and she will do it well. Can I come? Yes. You can mute my.
Good afternoon, everyone. Myself, Dr. G. Prem Lakshmi, final year postgraduate from the Department of Pediatrics, Sri Balaji Medical College and Hospital. Today, I'm going to discuss about an interesting case, eye-opener case where incessant cry was not just an irritability, but an underlying cardiac rhythm abnormalities. My moderators are Dr. Shanti Ramesh, Professor, Department of Pediatrics, Dr. Nivetha, Senior Resident from the Department of Pediatrics, Sri Balaji Medical College and Hospital. Case history: Muthiriyashri, 9-month-old female child, weight was 8.5 kg, admitted on 11/12/2025. Informant was mother, reliability was good, admitted with the chief complaints of excessive crying since 5 years. History of presenting illness: baby was apparently normal before few years, then mother noticed that the baby having incessant cry for the past 5 years associated with poor feeding and lethargy. No history of fever, no history of ear discharge, no history of diaper rash, no history of insect bite, no history of any vomiting and diarrhea, no history of any drug intake, no significant past history, attained all milestone appropriate for the age, immunized till age according to national immunization schedule. On primary assessment, airway was open, breathing was respiratory rate was 42 per minute, bilateral air entry present, work of breathing was normal, no added sound, saturation was 98% in room air, in circulation heart rate was 289 to 300 per minute, 100 to 190 per minute was normal for the age group, S1 present, S2 indistinct, no murmur, BP was 90/60 mm per Hg, CRT was less than 3 seconds, 3 plus 2 plus. In disability, GCS was 14/15. E4, V4, M6, bilateral pupil reacted to light. CBG was 103 milligram per deciliter. Temperature was 98.4 degree Fahrenheit. We took 12 lead ECG. Rate shows 280 per minute with narrow QRS complex with absent P wave. So we diagnosed as supraventricular tachycardia. Management: baby was received in PICU. Since the child had SPT with normal hemodynamics, we started on O2 via nasal prong. During vascular access, we applied ice pack for 15 to 20 seconds, followed by injection adenosine was given in the dosage of 0.1 mg per kg 1 mg, followed by rapid flush of 5 ml NS by 2 syringe technique. Follow this, reversion to normal rhythm happened. Baby was monitored in PICU for 24 hours and shifted to ward. ECG echo was done and found to be normal and was discharged after 48 hours. Baby is under regular follow-up in SBMCH. This was a video using stop cup. We are giving adenosine in 1 ml syringe at the dosage of 0.1 mg per kg. 0.9 mg is coming, followed by 5 ml flush is given in the another. This was a video taken during adenosine. This was the heart rate before adenosine. After giving adenosine, it is reverting back to normal rhythm. Approach to fast rhythm. Types of tachycardia: sinus tachycardia, supraventricular tachycardia, atrial fibrillation, atrial flutter, and ventricular tachycardia. In sinus tachycardia, it is a normal rhythm rate with fast rate, usually non-dangerous, commonly occur during fever and stress. In SVT, the rhythm originates above the ventricle. In atrial fibrillation, irregular heart rhythm will happen. In atrial flutter, characteristic sawtooth pattern on ECG will be seen. In ventricular tachycardia, rhythm originates in the ventricles. Pediatric tachyarrhythmias. Pediatric tachyarrhythmias are first divided into narrow complex or wide complex based on the QRS duration. If less than 0.09 seconds or too small square, it is called as narrow QRS complex. If more than 0.09 seconds, it's called as wide QRS complex. Causes for narrow QRS complex include sinus tachycardia, supraventricular tachycardia, atrial fibrillation, and atrial flutter. In wide complex QRS complex, causes include ventricular tachycardia and unusual SVT. Narrow QRS fast rhythm includes sinus tachycardia. It is the electrical discharge from the sinus faster than the normal. It is a physiological response to increased oxygen demand. It is not an arrhythmia but an exaggerated physiological response. Common causes include fever, pain, exercise, anxiety, hypovolemia, tissue hypoxia, anemia, trauma, toxins, and drugs. Supraventricular tachycardia. It is an abnormal fast rhythm originating above the ventricle. Presentation depends on the age of the child, duration of arrhythmia, and pre-existing cardiac status. Infants usually present with irritability, poor feeding, and pallor. Older children present with chest discomfort, palpitation, breathlessness, and fainting. Symptoms are often missed initially. Diagnosis is usually made when child develops signs of congestive cardiac failure and shock. Children with pre-existing cardiac function tolerate the arrhythmias poorly and decompensate faster and develop cardiac failure and cardiogenic shock. Sinus tachycardia and SVT. Sinus tachycardia is a gradual onset. SVT is abrupt onset. Heart rate cutoff is less than 220 per minute in infant. In children, it's less than 180 per minute. In infant SVT, heart rate will be 220 per minute. In children, more than 180 per minute. In sinus tachycardia, PV will be present, it will be normal. In SVT, PV will be absent and it is abnormal. RR interval will be varying in sinus tachycardia. In supraventricular tachycardia, it will be fixed. Adenosine. It is an antiarrhythmic drug indicated for a supraventricular tachycardia. Dose and administration. Administration is usually by intravenous and or intraosseous route. Dose is 0.1 mg per kg. For maximum dose, we can give up to 6 mg. Second dose is 0.2 mg per kg. We can give up to 12 mg. Mechanism of action, it transiently blocks the AV node conduction. Half-life is very short, is less than 10 seconds. Approach to tachycardia with normal hemodynamics. Approach to tachycardia in normal hemodynamics, we have to stabilize airway, breathing, and circulation. We have to confirm fast rhythm, then we have to check for QRS duration. If QRS duration is less than 0.09 seconds or less than 2 small square, we have to suspect ST or SVT. If SVT, while securing vascular access, we can try for vagal maneuvers, then followed by IV adenosine in the dose of 0.1 mg per kg. If no response, we can repeat the dose up to 0.2 mg per kg. Use rapid flush technique and confirm correct technique of adenosine administration. If fails, we have to reconfirm SVT. If still fails, we have to go for asynchronous cardioversion in the dose of 0.5 joules to 1 joules per kg. Same child present with shock, they have to stabilize airway, breathing, and circulation. If vascular access is available, we can go for adenosine, or else we have to tightly go for synchronous cardioversion. Thank you. I thank Dr. Shanti ma'am and Dr. Niveta ma'am for guiding throughout this presentation. I thank Dr. Sundari ma'am for giving this opportunity to present in the IAP Chengalpattu. Thank you.
I thank Prema for this excellent presentation of narrow complex tachycardia, namely SVT. She has followed the path. So she has followed the path for doing the ABCDE approach. The airway breathing circulation, disability and exposure approach to do our case. and the EEG was well demonstrated. Live video showing us the reversion of SV to ST following a rapid push of adenosine. So all this was the presentation was completed. So I thank her for this nice presentation. And now I call upon Dr. Niveda for our valuable comments.
Okay, good afternoon, everyone. I thank my department's team for giving me this wonderful opportunity. So, in pediatric tachyarrhythmias, the clinical presentation depends on the age of the child. So, in infants, the symptoms are going to be non-specific. They can present with excessive crying or irritability, lethargy, and poor feeding, or tachypnea. Unlike in older children, they can present with chest discomfort, palpitations, and rarely syncope. So here we emphasize to auscultate an infant presenting with incessant cry. And regarding the dose of regarding the adenosine administration, since it carries a short T-half and it gets metabolized by adenosine deaminase in erythrocytes, it must be administered by a rapid bolus technique through a venous access in the upper lip and preferably in a large vein. And the most common reason for non-response to adenosine is going to be your inappropriate administration. So make sure we are going to administer adenosine by a rapid bolus technique. Thank you.
It was well presented. Actually, the video was nice. So at the emergency taking a video, it was well demonstrated, the video part. Any underlying cause did you evaluate for recurrence?
So in the lab workup, CBC and electrolytes thyroid function tests were normal, and echocardiogram was also done after stabilization to rule out the heart diseases, and it was found to be normal, sir. And the child is currently under our regular follow-up, and the child doesn't have any recurrences at present, sir.
And how was it picked? You said, no, clinically the child was picked, or after, because the child would have been crying, right? So you had any difficulty in identifying initially, or?
No, the mother was shrewd enough to pick up the sign that the child is not well, the child is having incessant crying, and during our OPD itself, the child was having abnormal heart rate, which is not responding to the incessant cry, and the initial heart rate was around more than 220 per minute, and that was going to be abnormal, so we were able to pick up clinically, sir.
Okay, thank you. Well
Thank
managed.
you, sir. Thank you.
At this point, I like to also appreciate and thank our team, sir, because our unit, Dr. Niveda and team, because incessant cry, we think of simple things, arthritis media, hernia, and all that. But to pick up an SVT and to manage immediately within 20-30 minutes, that was a real it was a feast for us to see that the way things were going. Had we delayed this case for a few hours, I think we would have been in trouble, because quickly they will go in for cardiac failure, cardiogenic shock, and then we need to do synchronized cardioversion. Outcomes would be very variable. So we really were fortunate that we had team could pick up and manage this so well. So I will really thank each one of them for this. So now we'll, if there are no questions from the floor, shall I go on to the next case? Okay, so our third case for presentation today will be Tolosa-Hunt syndrome, and this will be presented by Dr. Rexina Darathi. She's from Chettinadu Hospital and Research Institute, and I welcome her to do a presentation, please. Dr. Rexina Darathi, are you ready with your presentation?
Yes, ma'am.
Sure. Shall we start?
Yes, ma'am.
Okay, thank you. Full screen, please. Yeah.
Good afternoon, everyone. I'm Dr. Rexina Darathi, presenting a case of painful nocturnal seizure in a child ultimately diagnosed as Tolosa-Hunt syndrome. This case highlights the importance of systematic exclusion of infectious, vascular, and autoimmune processes for diagnosing Tolosa-Hunt syndrome. Presenter is myself and moderator is Dr. Deepan sir. A 13-year-old female child, Miss Tamil Selvi, residing at Navalur, whose informant is mother, reliability is good, came with chief complaints of headache on and off for 4 weeks, drooping of left eyelid for 2 weeks. The child was apparently normal 4 weeks back, after which she developed headache, which was predominantly in the left supraorbital region, which was dull aching type, non-radiating, relieved with medication, not associated with visual or auditory aura, and vomiting. And 2 weeks later, child developed history of drooping of left eyelid, noticed by the teacher, associated with double vision when looking at a particular direction, and restriction of eye movements. So this temporal pain followed by pain involvement. There is no history of fever, cough, cold, running nose, ear pain or ear discharge, no history of decreased vision, photophobia, loss of sensation over the face or difficulty in mastication, no history of deviation of angle of mouth, drooping of saliva, no history of trauma to head, seizure, loss of consciousness, altered sensorium or projectile vomiting, no history of significant weight loss, loss of appetite and night sweats. So there was no history suggestive of any infection, raised intracranial pressure, pain, systemic illness. Antenatal history and birth history were uneventful. There was no similar illness in the past and no previous history of hospitalization. Developmental history, child attained developmental milestones appropriate for age. Now she's studying 8th standard with good scholastic performance. She was immunized up to age according to national immunization schedule. She was the first child not conceived in his marriage with no similar illness or tuberculosis contact in the family. Anthropometry measurement of the dental examination on admission, child was active, alert, afebrile, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Vitals, the child was hemodynamically stable, temperature of 98.6 degree Fahrenheit, measured in the right axilla. Pulse rate was 84 beats per minute, normal in volume, regular in rhythm, no radiofemoral delay, peripheral pulses were well felt, respiratory rate were 20 cycles per minute, abdominal thoracic type. Saturation was maintaining in room air. BP was 110/70 mm of Hg, which is 50th to 90th center for the range. Head-to-toe examination, it was normal in size. There was no facial dysmorphism. Left eye ptosis was present. Ears, throat, neck was normal. There was no neurocutaneous marker. Spine was normal. Genitalia was female phenotype, and SMR staging belongs to 3. Higher motor function was cranial nerve examination. She was able to perceive smell. Vision was 6/6. Bilateral pupil were equally reacting to light. Corneal and conjunctival reflexes were intact. Third, fourth, and sixth nerve. Left eye, there was restriction of abduction, adduction, elevation, levo depression, and levo elevation. Right side extraocular movements of full and free. And fifth nerve, the child was able to appreciate sensation over the face. There was no deviation of jaw. Other cranial nerve examination was unremarkable. Motor system examination was normal. Tone was normal in all 4 limbs. Power was 5/5 in all 4 limbs. Reflexes were normal. Plantars were flexor. Sensory system examination was normal. There were no cerebellar signs and no signs of meningeal irritation. Other systemic examination, RS bilateral air entry was present. There was no added zones. Cardiovascular system, S1, S2 present. No murmur. Abdominal examination, soft, non-tender, and no autonomy. The child was admitted with left-sided ptosis and multiple cranial nerve palsy with painful restriction of extraocular movements. The possible diagnosis considered were orbital apex syndrome, vascular causes such as cavernous sinus thrombosis, infective causes such as sinusitis with orbital extension, tuberculosis, fungal infection, and autoimmune causes include vasculitis. Inflammatory causes include IgG4 related diseases, Tolosa Hunt syndrome, and neoplasm. Baseline investigation including complete blood count, thyroid profile, liver and renal function tests were normal. ESR was not elevated. Coagulation profiles were also normal. The most crucial investigation in painful ophthalmoplegia is MRI brain and orbit contrast. This is an MRI image with contrast in the coronal section, focusing on the orbital apex and cavernous sinus. In this section, we can visualize the orbital apex, cavernous sinus region, and adjacent paranasal sinuses. On the left orbital apex, there was a small soft tissue lesion measuring approximately 1 cross 1.5 centimeter, showing heterogeneous contrast enhancement. This lesion appears to involve the orbital apex region, which is anatomically closely related to the cranial nerve responsible for the ocular movements. So the imaging appears suggests inflammatory soft tissue lesion rather than a vascular thrombosis or neoplasm. This correlates clinically with the child's painful ophthalmoplegia and involvement of the cranial nerve 3, 4, and 6. And this suggests inflammatory soft tissue lesion rather than a vascular thrombosis. Since sinusitis with orbital extension is a common cause in children, CT paranasal sinuses and ENT evaluation was performed. CT showed pansinusitis with occlusion of bilateral osteomeatal unit, frontoethmoidal disease, and sphenoethmoidal disease. There was deviated nasal septum towards the right side. And ENT evaluation was done. Diagnostic nasal endoscopy were done, and samples for gram stain, culture, and KOH mount fungal culture were done, and all results were negative. Other infective causes such as tuberculosis workup was done because orbital inflammatory lesions may occur due to tuberculosis. Although MAN2 was found to be positive, chest X-ray was normal, sputum AFB and gene export was negative. Pulmonary opinion was confirmed, and there was no active pulmonary disease. CSF analysis was done. Lumbar puncture was done to rule out CNS infection, meningitis, and malignancy. CSF findings was normal. It was acellular fluid, normal glucose, normal protein. Culture was sterile. AFB was negative, and there was no evidence of meningitis or CNS infection. Painful ophthalmoplegia may occur in systemic vasculitis such as granulomatosis polyangiitis. In view of this, C-ANCA and P-ANCA was done and both were negative. There was no other systemic features suggestive of vasculitis. Evaluation for IgG4 related diseases. Orbital inflammatory lesions can occur in IgG4 related diseases. Therefore, serum IgG4 levels were advised, though not performed due to financial constraints. However, there was no lacrimal gland enlargement, no systemic organ involvement. Thus, the probability of IgG4 related diseases remained low. Response to treatment. The final and most supportive evidence for Tolosa-Hunt syndrome is dramatic response to steroids. The child was started on oral tablet prednisolone at 1 mg per kg per day and continued for 7 days, and then tapered after excluding infectious causes and after a neurologist opinion. Following steroids, there was improvement in ptosis, extraocular movements, and this rapid response to steroids strongly supports Tolosa-Hunt syndrome. According to International Classification of Headache Disorders, the diagnosis of Tolosa-Hunt syndrome requires unilateral orbital pain, cranial nerve palsy of 3, 4, and 6 nerve, granulomatous inflammation in cavernous sinus or orbital apex on MRI, exclusion of other causes, and steroid responsiveness. In our case, all the 5 features were fulfilled. Discussion. Tolosa-Hunt syndrome. The syndrome falls within the spectrum of idiopathic orbital inflammatory diseases. It is a rare idiopathic granulomatous inflammatory condition of the cavernous sinus, superior orbital fissure or orbit. It is a diagnosis of exclusion. The condition presents with severe ocular pain and ophthalmoplegia due to paresis of cranial nerve 3, 4, and 6. Steroid responsiveness is used as the diagnostic marker. The estimate is per million. There is no male and female predisposition. In etiology, it is idiopathic by definition. It may occur as a result of non-specific chronic granulomatous inflammation in the region of the cavernous sinus or superior orbital fissure. Triggers, it can be a traumatic injury, tumors, or an aneurysm. It can be caused by non-specific granulomatous inflammation of the unknown etiology, chronic inflammation of the septa and wall of the cavernous sinus with proliferation of the fibroblast and an infiltration with lymphocytes and plasma cells. Such inflammatory changes in a tight connective tissue may exert pressure upon the penetrating nerves. Although there is no definite autoimmune etiology has been established, Tolosa-Hunt syndrome has been reported in association with systemic and autoimmune inflammatory conditions. Presentation hallmark of Tolosa-Hunt syndrome is the painful ophthalmoplegia. Pain is typically localized in the periorbital region. It can also occur in retroorbital, extending into the frontal and temporal areas. Tolosa-Hunt syndrome tends to have a relapsing and remitting course with attacks recurring every few months or years. Involvement of all three oculomotor nerves, oculomotor, trochlear, and abducens leading to the ophthalmoplegia. The ophthalmic branch of the trigeminal nerve is also commonly affected. Inflammation can involve the orbital apex, leading to optic nerve damage and consequent optic disc pallor or swelling. Loss of visual acuity in such cases is unpredictable and can be permanent. Tolosa-Hunt syndrome typically does not have any other neurological or systemic involvement. If left untreated, symptoms of Tolosa-Hunt syndrome can last up to 8 weeks, but often resolve spontaneously afterward. The differential diagnosis of Tolosa-Hunt syndrome includes all causes of painful ophthalmoplegia and therefore it's exceptionally broad. It is generally diagnosed based on the clinical presentation of painful ophthalmoplegia and neuroimaging studies to rule out other causes in response to steroids. Laboratory tests and CSF studies are supportive tests but help rule out other causes of ophthalmoplegia. So criteria for Tolosa-Hunt syndrome is unilateral headache, inclusion of both presence of granulomatous inflammation of the cavernous sinus, superior orbital fissure or orbit or any features change observed on MRI or biopsy, palsies of one or more oculomotor nerves, correlation of causes as evidenced by both of the following. Palsies of cranial nerve have followed a headache in 2 weeks or less or have developed simultaneously with a headache. Localization of headache around the eye on the same side, not better explained by any other headache etiology. Neuroimaging, MRI brain with contrast, especially the coronal view, is a crucial diagnostic study. Helps to exclude the other causes of diseases processes that produce painful ophthalmoplegia for better visualization of the image of the cavernous sinus and superior orbital fissure. Shows thickening of the cavernous sinus because of abnormal soft tissue, convexity of the lateral wall of the cavernous sinus. High resolution CT can also reveal changes in soft tissue. MR angiography, CT angiography, and digital subtraction angiography to know the vascular abnormality in intercavernous segments of the carotid artery, such as segmental narrowing, constriction, and irregularities. Other investigation on clinical presentation, MRI, blood, and CSF studies should be performed to rule out the other causes of painful ophthalmoplegia. Tolosa-Hunt syndrome remains a clinical diagnosis of exclusion. Blood investigation includes EBC, ESR, CRP, anti-nuclear antibody, anti-nuclear cytoplasmic antibody should be done. CSF studies include glucose protein, cell count, and differential cytology culture and blood stain to rule out the cause meningitis. Blood and CSF studies are expected to be normal in cases of Tolosa-Hunt syndrome. Glucocorticoid response. Glucocorticoid response play a key role in both diagnosis and treatment of Tolosa-Hunt syndrome. Treating with high doses of systemic steroid, dramatic improvement in pain within 2 to 3 days. Cranial nerve dysfunction improves and there is a reduction in abnormal tissue volume and signal intensity on MRI over the next few weeks of the steroid treatment. Reduction in pain helps confirm the diagnosis and is further supported by improvement and resolution of MRI findings. Glucocorticoids have been the main of treatment, involves initial high dose of therapy for a few days, over 10 months to be. Some patients require immunosuppressive other agents by the adverse treatments of long-term steroid therapy. Azathioprexate, mycophenolate, mofetil, cyclosporine used as a second-line therapy. Radiotherapy as for current drug to steroid. Process 1 syndrome is characterized by improvement but pain live observed within 4 to 72 hours and no palsy improvement gradually takes place. Residual neurological deficit after steroid treatments are usually rare and can be lateral, contralateral, or bilateral. Complication, it is a non-fatal and often self-limiting condition. Reduced limits most of the complication. Primary complication include permanent neurological deficit secondary to involvement of the cranial nerve 3, 4, and 6, resulting in ophthalmoplegia. Visual impairment may occur due to involvement. Relapses are common and may occur.
I think your presentation is complete. Or may I now request Dr. Deepan from Chettinad Medical College to for his valuable comments. Dr. Deepan can give us valuable insight regarding the case. Speak again. Doctor, I request Dr. Deepan to say to conclude the session with some insights and some valuable comments. I think there's a problem with the internet.
Ma'am, shall I continue, ma'am?
Sure.
Relapses are common and may require prolonged steroid therapy, increasing the risk of long-term steroid-related complications such as hyperglycemia, osteoporosis, and chronic immune suppression. Thank you.
Nice presentation from Dr. Rexina Darati on this syndrome. The photographs were nicely captured. The nice photographs, pre-treatment and post-treatment photographs showing the improvement in the ptosis and the ophthalmoplegia. It is very, very clear. And I like to now ask, request Dr. Deepan for his valuable comments and insights regarding the case.
Good afternoon.
Good afternoon.
This was initially presented as a painful ophthalmoplegia and ROPD only. Initially, we had multiple differential diagnoses. Common diagnosis like due to pansinusitis, orbital effects, or some other malignancies or any compression syndromes. Also, child had some pansinusitis. We also thought of any CNS infections. We had a multidisciplinary approach for this. And after imaging and some initial investigations, we found to have this inflammation which correlates towards Tolosa syndrome. And the typical triads of the ophthalmoplegia, painful the ptosis and granulomatous inflammations pointed towards this Tolosa syndrome. And it had a good response to initial few days of steroid therapy itself. Child significantly improved on the first 7 days itself on the starting the steroid treatment. And we are continued to taper off and we are continued on the rhodosteroids. So that's the scenario of this patient.
Thank you, sir. Any discussion? Anybody wants to ask any doubt from the audience? So I appreciate the team for their nice presentation and also a nice workup. As you said, this is a clinical, this painful ophthalmoplegia, a 13-year-old child presenting is a clinical diagnosis of extrusion. So they have nicely worked up all the, it's a multidisciplinary approach with working up, they have ruled out infections, tuberculosis, vascular clauses, vasculitis, and finally, with an MRI finding and a steroid responsiveness, they made a come to a diagnosis of Tolosa syndrome. So well worked up and well presented, sir. Thank you so much. Now we'll move on to the last case of today, trapped in acidosis, a metabolic mystery. So now I invite Dr. Soumya from Sri Sathya Sai Medical College and Hospital to do the presentation. Over to you, Sathya Sai.
Ma'am, from SRM, ma'am.
Yes, sir.
Case was well presented, ma'am. Actually,
well worked up, sir, also nicely.
Clinical presentation, workup, and management all were new for the PGs also. Nice, ma'am. Nice. Thank you, ma'am.
So, any follow up on this case? The child is doing well, no recurrence. I just like to know out of interest.
Yes, ma'am. Thank you, ma'am. Thank you.
Thank you, sir. So now I invite the last presenter for the day, Dr. Soumya from Sri Sathya Sai Medical College and Hospital, to do a presentation, Trapped in Acidosis, a Metabolic Mystery. Dr. Soumya, please start your presentation.
Hello. Hello. Good afternoon, ma'am. Am I audible?
Yeah, you're audible, but we're not able to see your screen, your presentation slides. Yes, you can go into a slideshow, please. Slides are visible. Full screen, please.
Yes, sir.
Yeah, just click on it and it'll be full screen. Okay, it's visible. Please, please go ahead.
Good afternoon, everyone. I am Dr. Soumya. I am the postgraduate from Chengai Medical College and Research Institute. And moderator is Dr. P. Suresh, Professor, Zoology Department of Pediatrics, and Dr. A. Karthik, his assistant professor. My case is about a 7.5-year-old male child who's presenting from Telugu.
Just a moment. Sorry for the interruption. Can you be a little louder because it's not very loud for us?
Yes, ma'am.
I think you speak near your laptop.
The child is 7.5-year-old male child, Jagdish, who was presently from Telugu by his mother, whose reliability is good, but she is complaining of cold coughs in 3 days, loose stools in 3 days, and fever since 1 year ago. On first day, child presented with fever, which is insidious in onset, and no documentation of fever was present with no diarrhea or variations or chills or rigors. The history of loose stools were present, which were watery in consistency, multiple in number, not associated with signs of reduced urine output. Cough. Cough is dry, non-paroxysmal, not associated with post-nasal vomiting, no diarrheal variations, nor aggravating or relieving factors. Seizures. One episode of seizure followed by uprolling of eyes after presenting to the ER. No history of difficulty breathing or peripheral edema, no history of weight loss or hemoptysis, no history of confusion or history of vision loss, no history of myalgia, arthralgia, no history of bleeding manifestations, no history of rash, itching, barefoot walking, no history of iris behavior impairments, no history of eating unequal milk or pasteurized milk, no history of pet exposure or COVID contacts. Associated negative history include no history of focal seizures in the past, no history of altered sensory in the past, no history of hereditary trauma or SIBO, no history of persistent vomiting or food feeding or cyanotic cells in the past, no history of meningitis symptoms or rash or fatigue, no previous history of symptoms or family history related to metabolic disorders, or no recent vaccination in the past. No history of episodic illness in the past or ICU admissions in the past, no history of seizures or jaundice or hypoglycemic episodes in the past, no history of recurrent vomitings or lethargy, no history of failure to thrive. The child is antenatal history is not known since the child is an adopted child and complications are not available. Later, the child is 3.25 liters born by a normal vaginal delivery and died immediately after birth with after of 8 and 9 and 5 minutes and no history suggestive of birth asphyxia. No history of eco-admissions in the past, and no history of neonatal seizures or hypoglycemia, no birth absence is given, and no following adverse effects following immunization. Developmentally, child was normally up to age and cross-motor was sitting with supported uretex regions present and monosyllables are able to speak monosyllables with DQ of around 92 to 93 with development appropriate for age. According to dietary choice for 24-hour recall method, that family deficit of 50 kilocalories and 3 gram protein deficit. Family history and socioeconomic history, dietary history is appropriate, and family history, child is adopted by his aunt, and no history, not a known history of genetic or hereditary disorders known. Social history, child belongs to lower middle class according to the modified Gotoswami scale. On general examination, child was dull looking at the time of admission, no history of pallor-ictus or cymostoclavic or lymphadenopathy edema. Confusion was 3 plus 1 plus and peripheries were cold and CRT was approximately 3 seconds. With heart rate of around 156 at presentation and respiratory rate of 75 and BP was 103 and temperature was 101. So according to the weight management, child was approximately 58 centile, which is mildly underweight for age, otherwise other unpermitted parameters are normal for age. On systemic examination, child has tachypnea and subposed retractions were present along with interposed retractions. Chest volumes were symmetrical and no chest wall deformity was noted. Chest expansion is symmetrical bilaterally and trachea was centrally placed, no chest wall tenderness was noted. On percussion, resonant note is heard bilaterally, bilateral layer is present with bilateral beats is present. No vocal cavities or bronchial response noted. On cardiovascular system examination, S1 and S2 were normally and abdominal examination soft and all normality was noted. On CNS, pupils were equally reactive and no focal neurological episodes noted. On course of day 1 of hospital, child was presented with low stools and fever, and after coming to the ER, child presented with one episode of seizure with uprolling of eyes. Tachycardia was present, tachypnea and hypoxia was present, and oxygen supplementation was started, and ideal and access was secured, and immediately shifted to care. This was child at the time of presentation. After child is shifted to PICO, CBG was low and started with IV dextrose bolus, and the baseline labs was sent and continuous monitoring was started. Child was immediately intubated because of low sensorium and started on normal lung ventilation with around on volume control ventilation with FiO of 40 to 50% and peak of 5. And our shock was loaded and empty and dosage was started at 0.3 micrograms per kg per minute and dosage for around 10 micrograms per kg per minute and continued. That was started on sepsis. And on ABG, high iron and metabolic acidosis was noted, and for which metabolic monitoring was done and soda bicarb correction was given. Anti-epileptic medication was started that medical after loading dose, maintenance dose was continued. This was ABG at the time of admission was pH of 6.86 and bicarb of 4.6, after which bicarb correction, soda bicarb correction was given. These were the lactate levels on the second day, which is 5.1. Initial lactate was low and later lactate was 5.1. Ammonia was 70 and ULC abdomen is normal. With MRI and CT brain being normal, CRP is 96. The child was extubated on the second day followed by HMS. This is the intubation. Post-PICU status. Later, child was known to have hypokalemia for which potassium correction was given, followed by maintenance potassium dose was given. And hemodynamics were maintained, so iron drops were gradually tapered down. And PIPAS was continued and stopped at day 7. And Hava was treated with continuous dextrose monitoring and metabolic monitoring. And anti-epileptic measures were slowly tapered down after taper. They were following recovery. No focal neurological excess were noted at 1 seizure on day 7 for which anti-epileptic medication was given, and PCS was then 15 by 15 later. This was ABG post-crisis phase. pH was 7.23 with Viva of 22. On day 30, coagulation parameters were delayed, so FFP was transfused. This was the child at discharge. So diagnosis, metabolic encephalopathy. Metabolic encephalopathy secondary to high amyloid metabolic acidosis with ketosis and normal ammonia levels suggest for probable organic ischemia. Advanced further metabolic evaluation for TMS and GCMS. However, patients' attenders were not willing to say at the present moment. These were the labs. Initial labs floating on week 20,000 and 27,000. Later, they came down after 2 days. They were active parties. LFTs. The other investigations. Summary. A 7.5-year-old male study present with AGE used tools with fever, generalized seizure, and audio sensorial on examination, tachycardia, tachypnea, hypoxia, and co-perfusion, and encephalopathy present requiring picocare. Investigation showed severe high anemia, metabolic acidosis with ketosis, and normal ammonia levels, the risk of probable organic ischemia precipitated by infection. What would be the differentials? Organic acidemia, why we are speaking about because of high anemia, metabolic acidosis and ketosis and encephalopathy present. Forms against an ammonia is often elevated and diabetic ketoacidosis. High anemia, metabolic acidosis will be present and marked ketosis and order sensory. Hyperglycemia will be present, but in this child, hypoglycemia is present initially. Starvation ketosis and history of fasting or more lower intake. But this mild acidosis will be present. Pancreas oxidation defects, encephalopathy during fasting levels will be present with hypoketotic hypoglycemia. Toxin ingestion can be ruled out because ketosis is usually absent in this. Simple nebulizer, no metabolic acidosis will be noted in this, and relatively rapid recovery will be noted. Asymptomatic seizure due to hypoglycemia, ketosis is usually minimal, acidosis is not typical, so can be ruled out. Sepsis with metabolic acidosis, ketosis is uncommon with lactic acid. Approach to IVF. If it's a typical clinical pattern, baby is normal at birth, symptoms appear usually after a trigger. Co-feeding, infection, fasting, and gastroenteritis are usually common features. Other features include vomiting, lethargy, poor feeding, hypotonia, altered sensory, and failure to thrive. In normal situations, ammonia breakdown, broken down stepwise, harms and products and converts into energy. But in organic ischemia, incomplete breakdown, which leads to organic ischemia accumulation, which leads to accumulation of these organic ischemia products and high anemia, metabolic acidosis, ketone body production relatively leads to toxic encephalopathy. Hormone biochemical findings include pH being low and anemia being high, ketones being present and ammonia being elevated. Lactates being elevated to normal, glucose is usually low normal levels, and urine and ammonia acids are elevated. Critical samples include blood glucose, ammonia, lactate, DBG, electrolytes, and even GCMS. This is the approach. Thank you.
I thank Soumya for this nice presentation. They have managed the case on the ventilator and the child has come out so well. Now I like to call upon Dr. Karthik for his expert comments.
Good afternoon.
Good afternoon. Yes.
Thank you, ma'am, for giving this opportunity. And I like my partner also for giving the opportunity to speak in front of all the committee. Ma'am, this case we have chosen to give light into two aspects. One, whenever we see encounter a child who is in encephalopathic condition, and when the blood gas shows high anionic gap and lactate being nearly to normal. In fact, the first blood gas showed lactate of 2.1 only, and later on it was 5.1. So when the lactate is near normal and the ACMA is present, and so far child did not have any other complaint developmentally, then we should seriously think of organic asthenias as a possibility, because organic asthenias, the unknown, when the acids start to compile or start to increase in the blood concentration, that will lead to the anion gap, and which is high anion gap metabolic acidosis. And that is first point. Second point, which I wanted to which I wanted to mention is these. As soon as we pick it up and we push the child's metabolism into anabolic phase, then the crisis evades and child completely recovers back. And in our situation, total time for the child to become normal was around 12 to 14 hours. And within 14 hours, child sensory improved. So we planned for early extubation, and then rest all things had followed. So these are the 2 points which I wanted to bring to in front of. Thank you, ma'am.
Any questions from the floor? Thank you, Dr. Karthik. Are there any questions from the floor? Would anybody like to ask some questions? So from my side, I just thought this 7.5 years old child, he seems to be a developmentally normal child. There was no microcephaly in your anthropometry. There's no failure to thrive. And no positive family history, and this is the first episode of seizure. So with this high anion gap metabolic acidosis, can we think of conditions like hypoxia, because child had hypoxia during seizures, you documented that, or sepsis in the ICU contributing to this metabolic derangement? Can we think of this common condition first? Is your child on follow-up? Is he having recurrent seizures? I'd just like to know the further follow-up, and were they willing to do a TMS at a later date?
Yes, ma'am. First, I'll take up the questions. One, considering hypoxia to be the etiology for seizures, yes, definitely sick children, when they present to the ER with seizures, definitely hypoxia is the first etiology. But here in this case, when at the time when he presented to ER, child was not in the state of complete lethargy or encephalopathy. He was irritable and he was responding. And soon, within 3-4 hours, when we noticed there was a drastic change in sensory of the child which required intubation. And hypoxia per se, because the lungs, here in this situation, child did not have communicable pneumonia prior to the presentation, so I won't consider hypoxia as well. And secondly, ICU requiring, we often see high anion gap metabolic acidosis, but not to the tune that the anion gap is somewhere as equal as like the bicarbonate. The bicarbonate in the initial value was not at all recordable. So considering my previous experience and seeing through the way the child behaved and seeing through the sudden change in metabolic milieu, I assume I would have my upper as my initial possibilities.
So my second small query is, on day 1, you have done an arterial blood gas analysis, and it displayed a very low sodium level of 112, and the potassium level was extremely high, it was 6. So what was the management done at this point of time? Because such derangement in the electrolytes, so life-threatening it was. And so what was done for this 112 sodium and potassium of 6?
Sodium, because it was an acute onset, we were not sure when the hyponatremia has occurred, though even the first study was 112. So we plan to correct a slower path of correcting sodium, and potassium correction was done with exposure insulin, and which helped in both ways for this child, I felt. later on thinking about it, because one, your glucose and potassium along with your insulin, it shifts the metabolism of the child to anabolism. That is one. And second, sodium correction was brought slowly with 3% NaCl, and which took us around 72 hours, if I'm not.
So thank you very much. Any further questions for this case? If there are no further questions, we like to conclude the session. All the 4 presenters, all the postgraduates did extremely well. There was a lot of involvement, and all the mentors also had given their contribution, guided the postgraduate to that presentation, and all cases were well managed. So we thank you once again for this lovely session, and it was indeed a good academic feast today afternoon. Thank you so much.